hormones.
Good morning, everyone. I would like to take this opportunity on behalf of Swisera Healthcare to introduce our moderator and convener for today's webinar, that's Dr. Sandhya Saharan. Doctor, I welcome you. Dr. Sandhya Saharan is a consultant obstetrician and gynecologist with special interest in endoscopy, infertility, and yoga. She is associated with Jupiter Hospital, Thane, LH Hiranandani Hospital, Kaushalya Medical Hospital, Cure IVF, and Birthing Hospital. The awards that she has on her names, and she's a proud winner of Young Scientist Award in the year 1994. She is a proud recipient of H. Desa Silver Jubilee Award in the year 2001. She has also won Best Paper in International Congress on Infertility in the year 2003 and Bharat Jyoti and Best Citizens of India Award in the year 2007. Apart from the awards on her name, she has devised a nomogram that is used for labor monitoring, and she is Vice President of Thane Obs-Gyn Society. She is also a Rotarian, a singer, and a dramatist. Thank you, Sandhya ma'am, and I hand over this to you.
Thank you so much, Smita, for the kind introduction. First of all, let me welcome this August gathering to this beautiful webinar on PCOS, tip of the iceberg. I seek to invoke the blessings of Lord Ganesha. We are in the midst of Ganesh Utsav to make an auspicious start to our webinar. So let us pray and start this with a small invocation to Ganesha. Vakratunda Mahakaya Surya Koti Samaprabha Nirvignam Kurumdeva Sarvakaryeshu Sarvada. So again, a very hearty welcome to all of us. And I invite our president, Dr. Rajiv Laul, to welcome our audience. And also I would like to introduce him. He is the president of the Thane Obstetrics and Gynecological Society. He is also a professor at the Rajiv Gandhi Medical College and Kalwa Hospital. He's been practicing at Renuka Nursing Home for the past 30 years. Sir is an avid marathon runner and a singer par excellence. He is going to also chair the session of Dr. Norman along with our General Secretary, Dr. Datta Panandikar, who is a gynecological and endoscopic surgeon practicing in Thane for the past 22 years. He has done his MD from GMC and JJ Group of Hospitals. He has stood first in the MD exam in 1989. He's trained in laparoscopic surgery under Dr. Kurt Sem, and he is a well-known gynecologist and one of the favorite practicing gynecologists in Thane district. He's also won the Icon of Thane Award. So with these words, I welcome our president, Dr. Rajiv Laul, to invite us and give his presidential address.
Hello everyone, a very good morning to all of you friends, and a warm welcome to all the delegates attending this live international webinar organized by Thane Obstetrics and Gynecological Society along with PCOS Society. The topic is PCOS, tip of iceberg. Now friends, PCOS is the most common endocrinopathy that affects women, with features of menstrual dysfunction, anovulation, infertility, hyperandrogenism, insulin resistance, and obesity. Reported incidence being 4 to 20%. There is a prevalence of 9 to 35% in adolescents. 20% of women in India suffer from PCOS. The etiology is not known, but may be genetic. So to unravel the mysteries of this heterogeneous disorder, PCOS, we have invited an international faculty, Dr. Robert Norman, whose topic is obesity and PCOS. This will be followed by Dr. Duru Shah's talk on impact of AMH in PCOS women. Then that will be followed by a power-packed panel discussion moderated by our Vice President Talks, Dr. Sandhya Saharan, case scenarios on PCOS through the ages. Our panelists are Dr. Neelima Shilotri, Dr. Alaka Godbole, Dr. Supriya Arwari, Dr. Padmavathy Menon, Dr. Rachana Deshpande, with expert comments from Dr. Robert Norman and Dr. Duru Shah. Organizing Secretary is Dr. Datta Panandikar. Our academic partner is Vizera Pharma. And thank you, Mr. Subhojit and Ranjit Pathania, for arranging the platform for this webinar at such a short notice. Now, I would like to introduce Professor Robert Norman. It is indeed a proud privilege for me to introduce Professor Robert Norman. Dr. Robert Norman holds a personal chair as Professor for Reproductive and Periconceptual Medicine at University of Adelaide. He is a subspecialist in reproductive medicine and in endocrine biochemistry. He was director of Robinson Research Institute at the University of Adelaide from 2008 to 2013, a collection of 60 research leaders in reproductive health and regenerative medicine with more than 450 members. He has been leader of 2 NHMRC program grants and has published over 450 peer-reviewed publications and 1 book. He has an H score of 103 Google Scholar with more than 48,700 citations. He serves on the editorial board of major reproductive journals. Today, he has been given his major research contributions has been in IVF and reproductive endocrinology, particularly in PCOS, the effect of lifestyle on reproductive outcomes and periconception medicine. He is the former medical director and an active reproductive medicine specialist at the Fertility SA and formerly CEO of Repromed Private Limited. He was president of Asia Pacific Initiative for Reproduction Society with membership of more than 2,000. Scientific chair of Aspire, scientific chair of Fertility Society at present. He was awarded an Order of Australia in 2013. In 2015, he became a fellow of Australian Academy of Health and Medical Sciences. And in the same year was awarded an honorary Doctor of Medicine by University of Adelaide. He has been given the top awards of American Society of Reproductive Medicine, European Society of Human Reproduction and Embryology, and the Asia Pacific Initiative on Reproduction. With this brief introduction, I would now invite Dr. Robert Norman to start his talk on obesity and PCOS. Over to you, Dr. Robert Norman.
Thank you very much and good morning, everybody. Behind me, you can see some Aboriginal paintings, which I think will give you the context in which I've been working. And I have always appreciated my Indian friends learning something about Hinduism and your culture as well. Obesity is very, very common in patients with PCOS. So I thought I would remind you about how obesity has an impact on PCOS and also on pregnancy and fertility generally. So what am I going to try and cover in this talk? Well, first of all, I want to talk a little bit about the fact that nutrition is really important in successful reproduction. Sorry, I've had somebody. Excuse me. This is one of the problems when you're on Zoom, having people phone you and you can't stop them. I apologize for that. So the second thing I'd like to cover is obesity effects on pregnancy. Then I want to talk about obesity effects on getting pregnant, obesity effects on male fertility, and then practical approaches to fertility care in obesity. So let me remind you of the interaction of nutrition with reproduction. And we often forget about it in our daily work, but it's incredibly important. So the pancreas and the fat cells produce substances that have a big impact on the hormonal profile by which the ovary and reproduction works. So fat cells are particularly known for producing leptin, which controls appetite, but they also produce many other adipocytokines that I'm not going to go into, but many of these substances work on the ovary. And the more fat you have, the more it impacts on ovarian function. Insulin is also known to work very closely with reproduction. There are insulin receptors in the ovary, and there are also insulin receptors in the pituitary and the hypothalamus. You'll know the positive and negative feedback process between the pituitary gland and the ovary. And as a child reaches puberty, so we start having nocturnal production of LH and FSH. And finally, we start getting feedback processes whereby estrogen and inhibin talk back to the brain. So physiological hyperinsulinemia is common at puberty, and it amplifies the effects of sex steroids by reducing sex hormone binding globulin. In undernourishment, you get very low levels of fat cells, you get low levels of insulin, and associated with this is a reduction in LH and FSH, and therefore the ovary goes to sleep. So you tend to get delayed puberty and amenorrhea. And this is something which throughout our history as a human race, we've seen a lot of. So malnutrition as a result of famine and lack of food leads to reproductive delays and therefore delay in puberty. What we're facing now is overweight, and this is where we get a vast excess of fat, increased insulin resistance, and large amounts of adipocytokines and leptin working on the brain and on the ovary. And as a result, we tend to get earlier menarche, we tend to get reproductive problems that occur. And although you in India are seeing largely people who are undernourished, in the cities, there's an increasing degree of overweight and obesity. So just to summarize what we see with overnutrition, so we get early puberty and menstrual abnormalities. We have lack of ovulation often and infertility. Androgens are produced by fat cells by conversion from weak hormones, and they're increased. We see an increase in miscarriage, gestational diabetes, and many other complications that occur. The good news is this can be reversed with caloric redistribution. It's important to realize that weight has a big impact on your chance of fertility. So on the left-hand side here, sorry, I have to go back again. On the left-hand side, we look at the relative risk of infertility from the Nurses' Health Study in the United States. And the green shadow is the normal weight range. And you'll see that as the BMI increases, so the risk of infertility increases dramatically. On the right-hand side, we see menstrual abnormalities. And again, as the BMI goes up, so we see menstrual irregularities. However, the degree of infertility change is much greater than that of menstrual abnormalities. So we can't explain everything on the fact that people are having irregular cycles. So about 66% of anovulatory infertility can be historically attributed to poor diet and exercise. The other thing to point out is it's not just your BMI and weight that's important, and this is particularly true in PCOS. It's where the weight is and where the fat is distributed. So this is a study done from the Netherlands where they looked at women who were perfectly fertile, having regular cycles, but they were married to a husband who had no sperm. And they had to undergo donor insemination. And over the course of several cycles, people got pregnant. Now, in the pink here is where the waist-hip ratio was less than 0.8. So this is typical of someone we would say has a pear-shaped obesity. So all the fat is on the hips and not much on the abdomen, whereas in purple are those that are apple-shaped. So they have mainly fat on the abdomen and less on the hips. And you'll see those who had exactly the same BMI as those who were apple-shaped, but the pear-shaped people got pregnant much quicker. And so this indicates that regardless of your BMI, it depends where your fat is. And in PCOS, we tend to have patients who largely have fat centrally, in addition to peripherally. In Australia, we've followed 8,000 women and looked at self-reported PCOS. And we've shown that as women change their BMI over 10 years, so PCOS goes up. So on the left here are women who had a BMI of less than 25 and stayed at a BMI of 25. They only had a 4% PCOS rate. If we look at the right-hand side, these are women who had a BMI of 25 and under, who then developed a BMI of 30 because they put on weight. And you'll see that PCOS increased. So if you've got a tendency for PCOS and you've got a low weight, it's less likely to be a problem. But if you've got a tendency to PCOS and you put on weight, it will be revealed. And this is one of the problems that we are facing around the world at the moment. So what about fertility treatment when it comes to patients who are overweight? Well, there's a greater prevalence of anovulation, and this is particularly true in patients with PCOS. They often don't respond very well to ovulatory drugs. You often need to give FSH with higher doses. And once you start doing that, you run the risk of multiple pregnancy. If you then move to IVF, you're using much more dose of FSH, and therefore the cost is much more. There are many complications with operation and anesthetics. A woman with a high BMI and PCOS undergoing IVF has a lower chance of pregnancy and a higher chance of miscarriage. And there's a higher chance of multiple pregnancy as well. And it's interesting when you look at third-party reproduction, the BMI of the egg donor is more important than that of the recipient. And I'm not going to cover it very much here, but if you've got PCOS and you're overweight, you have significant metabolic problems. You're much more likely to be diabetic, to have high blood pressure and hyperlipidemia, and also fatty liver. I'd like to remind you that it's not just PCOS that increases miscarriage. In fact, we don't think PCOS does increase miscarriage, but it's obesity does it. And these are the number of studies that you can look at. And if you just concentrate on the blue here, the miscarriage rate generally, you have an odds ratio of 1.31 if you're obese compared to normal. Recurrent miscarriage rate is an odds ratio of 3.5, so 3.5 times more common. And if you have had a miscarriage rate, the chance of your next miscarriage is going to be 1.7. So obesity increases miscarriage regardless of whether you've got PCOS or not. This will be known to most of you, the other hazards of maternal obesity. So I've discussed about before conception with reduced fertility, increased pregnancy loss. But then you'll see during pregnancy, there are many complications that occur, including diabetes and pregnancy hypertension, as well as preterm delivery. At birth, there are many complications that are more common to the obese woman, including infection and operative problems. all of these are magnified in an obese woman with PCOS. But we often forget the risk to the offspring. So obese women have a higher risk of having a congenital abnormality and a baby that's either small for dates or large for dates. At birth, we tend to get increased adiposity, and in the long term, we know that children born to obese mothers and PCOS mothers have higher risks of metabolic problems. I'm not going to go through a lot of the biochemistry as to why this is, but this just really summarizes what I want to say. So maternal obesity, where there's a metabolic syndrome, as in PCOS, the eggs are abnormal and they are definitely affected. They're loaded with fat, they've got reactive oxygen species in there, and there are problems with the endoplasmic reticulum. I'm going to talk a little bit about men. We get abnormal chromatin in the sperm, and when we produce an embryo, we get a different embryo phenotype, and we're more likely to get abnormal epigenetic reprogramming. So basically, an overweight PCOS woman with an overweight man has a much higher risk of producing an abnormal embryo and problems in pregnancy. And this just summarizes the effects of being overweight on the embryo in women. So the eggs are abnormal and ovulation is abnormal. The fallopian tube has got different secretions which do not promote the growth of the embryo in the same way. And once it reaches the endometrium, you have an abnormal endometrium with an abnormal immune function. If you've got an overweight man, he's producing semen and seminal fluid that is not typical of what it should be, and you tend to get an abnormal embryo. And if you think of what we do in IVF, we've really got together a concoction of culture media, which we think approximates what goes on in the body, but it's only an approximation. What happens in the male? We're getting more and more information now that the overweight male has an abnormal seminal fluid. The cytokines are different in that. And we get epigenetic abnormalities going on in the sperm. And there are changes in histone-bound DNA and the microRNA. And again, this impacts on the developing embryo. I'd like to remind you that in the male person that you're seeing in an infertile couple, that the male has got DNA damage in his germline if he's overweight. There's oxidative stress. And even if you get fertilization, you have a much higher risk of DNA mutation in the germline, which leads the child to have a risk of other diseases later in life. And finally, let me just talk a little bit about the overweight male in IVF. We looked at 350 cycles of IVF where we documented the BMI of the male, and the female weight was the same across all the group that we looked at. And we showed decreased pregnancy rates, increased pregnancy loss, and much worse embryos. So in the top right-hand corner here, you'll see the male BMI and the results on live birth, and it goes down as the guy gets heavier. And on the bottom, we saw the embryo development depending on the paternal BMI. And you'll see that on-time blastocyst numbers go down and expanded blastocysts go down. And so one of the messages I'd like to get across to all of you is that although you're seeing a woman with PCOS, you're often seeing a very overweight man as well. And that you could be wasting a lot of your time and energy by just dealing with the woman if you're not also dealing with the couple. So let's briefly talk about practical approaches to infertility treatment in the overweight couple where PCOS is present. Well, there's some important things. We need to approach a dietary intervention. We need to discuss increased intervention within the cultural environment in which the couple work. and we need to talk about behavioral intervention. So there are effective lifestyle interventions. There are different diets that will work for some people. But the problem is how to deliver these and how to motivate people to get substantial weight loss prior to getting pregnant. One of the messages that I think is worth getting across is when you see a young teenager with PCOS, it's really important to emphasize the prevention of weight gain. Rather than seeing somebody aged 25 or 30 who's got a BMI of 40, it's much better as a teenager to emphasize how they should try and reduce the weight gain that they get. And so in the family, to persuade the mother and father that their child, in fact the whole family, should be on a much lower calorie diet than perhaps they're on at the moment. But what happens if somebody wants to go onto a diet to lose weight? Well, as you know, there are numerous diets. There are probably about 1,000 different fertility diets around the place. Most of them talk about avoiding trans fats, having unsaturated vegetable oils, extra folic acid, everything up on that list that I show you there. But the approach to a diet is probably much more important than the actual diet itself. So we talk about caloric restriction. That's usually portion size, making sure that people limit how much they're eating. I use a system of meal replacement quite often, and these are commercial products where you get low calories and you replace a meal or 3 meals a day with a low calorie meal replacement. In our part of the world, intermittent fasting is becoming very popular, and that's where you can eat what you want for 5 days a week, but 2 days a week you actually fast. I've got very little experience of drugs, but some people in the world will use drugs to stop people eating. And bariatric surgery is expensive, but very, very effective. It's worth helping people to get educational resources about getting pregnant and what they should do. We have a very well-known program called Your Fertility, and the web address is down in the bottom left-hand here. And this gives us advice to the patient on a variety of things, and you'll see them there on the website, but in particular, weight. So this is what's done for weight for people planning a pregnancy. And there's some nice videos. There's lots of information about diets and weight here. So we get all our patients to read this. We also have lifestyle intervention programs. Originally, we had a thing called Fertility Fitness for Women. And this is where women would come once a week for 3 hours to do exercise, get dietary advice, and to meet with a gynecologist, a nurse, a physician, and to really get motivated to lose weight. And we found that there was a 50% increase in natural pregnancy rates, a much higher chance of getting pregnant with IVF. In recent years, we've moved to what we call a fertility assessment project, and this is where the couple meet with a nurse, and the nurse goes through a questionnaire, gives them advice, informs the physician, and then follows them up. And again, we've had very good results with this. What about anovulation in PCOS? Well, there now is no doubt that letrozole is the first-line therapy, and I stand open to correction, but I think you're allowed to use it in India again. Clomiphene citrate is still excellent, and if you combine it with metformin, is as good as letrozole. Metformin is excellent if you are not in a hurry to get pregnant. And if you've got experience with FSH ovulation induction and the patient can afford it, it does seem to work very well. We use a lot of FSH ovulation induction for failed oral induction, and we have a very low multiple pregnancy rate. What about IVF with PCOS? We always encourage our patients to lose weight gradually for a couple of months beforehand. We involve the partner and we want to see metabolic improvement. We want to see the sugar normal, lipids satisfactory. There should be a lower gonadotrophin dose. We should really be trying to use less than 150 units of gonadotrophin on IVF cycle. I'll often start on 75. We need to recognize there's difficulty with egg recovery in an obese woman, and there's often difficulty with anesthetic. There's a risk of deep vein thrombosis, and miscarriage can occur. So we always use a GnRH antagonist cycle with a GnRH agonist, and there's now quite good evidence that a freeze-all cycle gives you a better result than a fresh embryo transfer. What about bariatric surgery? Well, there's improved menstrual regularity, decreased fertility interventions, and often PCOS will resolve quite well. And you'll get very marked metabolic improvements and normal cycles again. So, to summarize, how do we care for the overweight, infertile woman? Well, it's very important that she holds the management plan and that she's central to the whole discussion. Primary care is important. If she's got a general practitioner, that he or she is involved in looking after them. You need good education resources and consumer support websites. The PCOS Society of India is brilliant on this, and you'll find lots of information there. It's important to have good specialists, an endocrinologist, gynecologist, fertility specialist. And if the patient can afford it and you've got access to it, a psychologist, dietitian, exercise physiologist. So I think this is the secret to the care of obesity, PCOS, and fertility for the couples that we see. And we need to recognize that the patient is central to everything that we do, and that we need to individualize treatment for them. So with that, I will end. Thank you very much.
Thank you, sir. This is Dr. Datta from Mumbai. I think this is one of the most exquisite lectures that I have attended on the polycystic ovarian disease. Sir, I have two questions for you. We are seeing more and more unmarried girls with polycystic ovaries. Some of them are obese, while some of them are not. So what is your advice to these young girls besides taking care of their weight?
Sorry, can you just repeat that, because I had a lot of noise in my background here.
Yeah, I want to ask you, we are seeing more and more unmarried young girls with the polycystic ovary. Most of them are obese, but some of them are not obese. So what do you think is the best treatment that we can offer them?
So for the non-obese young women, we need to recognize that if you do a check of the fat distribution in them, and this is a research process, it's not something you necessarily do clinically, they have more fat in the abdomen than the average person who has the same BMI as them. So even if somebody's got a normal weight, they've got probably abnormal fat distribution with PCOS. And therefore, although you don't want them to lose weight, they probably, we know, they have got insulin resistance. They may well respond well to metformin, and they may benefit by improving their exercise and perhaps going for low GI foods. So there's a lot of lifestyle modification that can be done that doesn't involve weight loss. As they're unmarried, they're not looking to get pregnant, and if their cycles don't come back to normal, the oral contraceptive pill is very good at controlling cycles with no worsening of the metabolic problems. So I think the thin PCOS woman is a challenge. If she's not trying to get pregnant, there's time to get good lifestyle changes.
Yeah. So what about metformin for these young girls?
Well, if you do the gold standard test for insulin resistance, which is the euglycemic clamp, and again, I emphasize this is not a clinical thing that we would do, you'll find that the majority of these women are insulin resistant. And therefore, I think metformin has a role to play, even if they are normal weight. Metformin, as you know, is a pretty safe drug as long as you don't get gastrointestinal side effects and can be continued long term. So that combined with things that lower your insulin, such as exercise and a reasonable diet, I think are what we would recommend for a woman like that.
Yeah. So you, along with Professor Teed, have developed the guidelines for diagnosis and treatment of polycystic ovarian syndrome, which were published in July 2018. So can you give us some insight on what prompted you to do this kind of research and how you went after it?
Thank you very much for mentioning that, because I think more than listening to me, people will get benefit by looking at the international guidelines. If you don't know where to get them, Duru, Shah and PCOS Society of India will point you in that direction. The reason we did this was that we got complaints from patients the whole time. They said, I go to Dr. A, he says I haven't got PCOS. I go to Dr. B, he says I've got PCOS. I go to somebody else and they tell me I need metformin. Someone else tells me I need IVF. I have not been investigated properly. I'm told I need to have a glucose tolerance test or a test of sugar. No one's ever offered that to me. And so our patients were complaining the whole time that we as a community in Australia had not got all the doctors to agree on how to investigate and diagnose and manage PCOS. And then we realized this is a problem all over the world. And so we started off in Australia, but then we included countries all over the world. So we included India through Duru Shah and Jaideep Malhotra, ASRM, ESHRE. So basically, we have now got agreement throughout the whole world on how to diagnose PCOS and what evidence-based treatment is. And this is clearly available to patients and it's available to doctors. So rather than this just being our opinion, we've got evidence-based, we've got approval of all the major organizations in the world and most of the key doctors.
Yeah. So we've got a few questions from our viewers. We are talking about metformin, but there is a new drug on in the market that is myoinositol. So what are your views on myoinositol versus metformin?
So there was a couple of papers in the New England Journal of Medicine and other journals about 10 years ago promoting inositol for ovulation induction in patients with PCOS. And a big trial was done and was abandoned because there was no difference. However, the Cochrane review at the moment is suggesting that inositol is probably effective. And I know myoinositol has also been trialed a lot. Whenever I come to India, I see all the booths advertising inositol and myoinositol. So I think your experience in India is far greater than our experience here in Australia. I was very skeptical, but I am more positive now that I think there probably is quite a lot of truth that these drugs are effective. I'd be very interested to know from others on today.
Yeah, yes, sir. So do you think I should do the serum insulin levels for every patient before I start them on metformin? And what do you think is the best test for insulin resistance?
Thank you for that question. Doctors are very divided on this issue. I personally do not measure insulin because almost every single patient by definition is insulin resistant. So it doesn't help me with my management. There's no evidence that giving metformin is dependent on the insulin levels. So you can have a normal insulin level and still get benefit from metformin. However, other doctors I know use insulin measurements because they say to the patient, look, here's the number, your insulin's far too high. And it may be motivational for patients to then try and lose some weight and take action and see the number drop. But measuring insulin, if the patient's paying for it, is expensive. And I think it's probably not that necessary. Sorry, the second part of your question?
What do you think is the best test for insulin resistance?
Okay, so the best test for insulin resistance is a tape measure around the stomach and around the hips and the waist-hip ratio. That's the simplest thing to do. The most complicated is a research method that none of us are going to do called a euglycemic clamp. It is possible to measure the insulin and to then measure the glucose and work out a ratio. That's often called HOMA-IR or Quickie. That can be done, and that is an approximation to insulin resistance. I always measure SHBG when I measure testosterone. And a low SHBG is often a very good sign of insulin resistance because not only does the androgens lower testosterone, but insulin does it as well. And often when patients' insulin resistance gets better, their SHBG goes up. So there's no easy answer to that. Everything is an approximation unless you do the very complicated method.
Yes, thank you very much, sir. I think we are through with most of the questions which have been asked by our viewers, and as the webinar progresses, there will be many more which we will definitely would like to know your views. I now hand over to Dr. Sandhya Saharan for the second part of our webinar. Sandhya, are you there?
Yes, thank you so much, Dr. Pandikar, and thank you, Dr. Norman. That was a very, very lucid and very informative presentation. I now welcome our chairpersons for the next session, Dr. Kalyan Barmade and Dr. Abhijit Kohli. Dr. Kalyan Barmade is the chairperson of the Public Awareness Committee of FOXI. He is an ex-council member of IAGE, MSR and AMOGS. He is also the organizing secretary of various conferences. His mission is Save the Uterus, and that is the coordinator for FOXI 2019 and 20. He is from Latur, and he is a very well-known figure in the entire of Maharashtra, and I would say India. Welcome, Dr. Kalyan. Along with him, chairing the session will be Dr. Abhijit Kohli. He is the director of the Hope Fertility Clinic. He's been practicing in Thane for the past more than 25 years. He has worked with Dr. Indira Hinduja, the pioneer of IVF in India, and they were also instrumental in bringing the first test tube baby to India. He was actively involved in this at the KEM hospital. He's got trained from Sydney IVF Center, and he is also has been in the field for IVF for the past 32 years. Welcome, Dr. Kohli. Over to Dr. Kalyan.
Very good morning to all. I'm really glad to introduce my teacher, Dr. Duru Shah Madam, who is going to give a talk on the impact of serum AMH in PCOS women. Can I have a PPT? Dr. Duru Shah Madam runs the Center for Women's Health and Fertility in Mumbai. She's the founder president of ICEBERG Society of India. She's a consultant gynecologist and fertility expert at Deshpande Hospital, Godbole Hospital, Hinduja Healthcare Mumbai, and she's a past president of prestigious PCOS, Indian Menopause Society, and ISAR. She's the founder trustee of Women's Empowerment Foundation, who is doing a lot of good job. And she's the first and only Indian to receive the Distinguished Merit Award for services towards women's health. The OPTR recognition award by Honorary Minister of State, Srimati Anupriya Patel for outstanding contribution in the field of human health in 2018. She's the Honorary Fellow of the Royal College of Obstetrics and Gynecology, and she's a past chair of Indian College of Obstetricians, and she's a chair of various international special interest groups like Aspire. I welcome Dr. Duru Shah, madam. I'm very glad that she has done so many surveys and so many research work in rural India also, and one of the work is going on in Latur on Indian Menopause Society. Welcome, Dr. Duru Shah, madam.
তোমার বৌমাকে পাঠাও বসে বসে শুধু ঠ্যাং দুলিয়ে দুলিয়ে শুধু খেতে এসছে
Dr. Duru Shah, madam, is going to give a talk on impact of serum AMH in PCOS women. Can you unmute, ma'am?
Yeah, I've unmuted. Can you all hear me?
Yes, ma'am.
Yes, madam, we can hear you.
Yes, madam.
Yes. So today I will be speaking to you on AMH, and I will be talking about the advantages of using AMH in PCOS. I need to move my slides. So. Okay, I've got it now. So the impact of AMH in PCOS women. Before I start, I must say I truly enjoyed Rob's talk. He's a fantastic speaker, and he reaches out to the audience and gives the right messages, which I hope I can give too. So we will talk today about the impact of AMH in PCOS. And what AMH stands for is anti-Mullerian hormone. And to give a brief history on AMH, it was first isolated and purified in 1984. The gene for AMH and its receptor was sequenced in 1986, and it was cloned in 1994. It was first identified in fetal testes, which induces regression of Mullerian ducts. So it is in the male fetus that AMH first comes into circulation, and that helps to regress the Mullerian ducts if it is a male child, and if the testes are present. And if there is no testes present, then the Mullerian ducts continue to grow. And in the female fetus, you will find that the AMH comes in by the 25th week of gestation and stays in circulation till menopause. Now, this AMH is produced by the preantral and antral follicles, and mainly it inhibits the early stages of follicular development. In women, it is expressed by follicles of 4 to 6 millimeters. It gets into circulation and is recorded as serum AMH. And when the AMH levels are good, it is called good ovarian reserve, which is in the normal range. But when they are high, we find that the more the number of follicles seen in the ovaries, more is the amount of AMH which is produced. And that's why in PCO patients, when there are many follicles in the ovaries, you'll find that the AMH levels are higher. And if there is very, very low AMH, it's possible that this AMH is exhausting the follicular pool, because when AMH is low, the follicles keep growing. Normally, AMH controls the growth of the follicles, but when AMH is less in the blood or less production is there, then the follicles do continue to grow faster and they get over very soon, and this can lead to premature ovarian failure. Now, AMH secretion in PCOS is almost 2 to 3 times in the blood more in PCOS as compared to other women who are non-PCOS. But if you count it, if you measure it in the granulosa cells of the ovaries, in PCO patients, it's 75 times higher levels versus normal ovaries. It's also seen to be increased in insulin-resistant women, and in those women who are totally amenorrheic, it will be much higher as compared to those women who are getting delayed cycles. An AMH level is not being used for diagnosing PCOS today, because the level is such that though the sensitivity and specificity may be about 83%, but there's a lot of overlap between, you know, the normal and the abnormal, and hence it has not yet been used for the diagnosis of PCOS. But on an average, you find that a level of about 5 nanograms per ml and above would probably make you suspect that there could be PCOS. Now, AMH is being used in various situations, as I suggested, for diagnostic marker, diagnosis of ovarian reserve. It can be used as a predictive marker for ovarian response when we are doing ovulation induction or hyperstimulation. It's a predictive marker for hyperstimulation of the ovaries, and also could be a predictive marker for success in assisted reproductive technology. Now let's look at diagnosis of PCOS. Now here, when we have talked about the Rotterdam criteria, we all know that there are 2 conditions out of 3 which need to be fulfilled. So one of them is purely clinical, oligo or anovulation. And the second is where there is clinical signs of hyperandrogenism, that is acne, hirsutism, alopecia, or it could be even the blood levels showing high levels of androgens. And the third option is where there is polycystic ovaries with more than 12 follicles measuring 2 to 9 millimeters in diameter, or an ovarian volume which is more than 10 ml in each ovary. Besides this, we have to exclude other situations such as congenital adrenal hyperplasia, androgen secreting tumors, and Cushing's syndrome. So based on these criteria, there are 4 phenotypes, as Dr. Rob has already discussed. And we need to go into the international guidelines where we did discuss AMH. And you see this paper by Helena Teed with Rob Norman being there, and me too. We were all involved in the development of this paper. So here we looked at investigating whether AMH is effective for the detection of polycystic ovarian morphology and for the diagnosis of polycystic ovarian syndrome. The 2 are separate because PCOM is morphology as seen on ultrasound, while PCOS is based on Rotterdam criteria of 2 out of 3 being present. Now this was a huge data collection, and this was done from various electronic databases and systematic reviews. And the conclusion was that although serum AMH levels in adolescent and adult PCOS women are significantly higher in polycystic ovarian morphology versus non-polycystic morphology, means where the ovaries are looking normal, and also in PCOS versus non-PCOS, there is a significant overlap between cases and controls. And hence today, the evidence for AMH is of limited quality. So the evidence-based recommendation was that serum AMH level should not yet be used as an alternative for the detection of PCOM or as a single test for the diagnosis of PCOS. But the clinical practice point is that there is emerging evidence that when there is better standardization of AMH assays, there are established cutoff levels, and when we have more accuracy in the AMH assays, because there are different platforms of AMH use which have different sensitivities and different indices. So in short, we need to get a sort of a standardization done before we can use it as a diagnostic marker. Now, this study done by Enrico Camina et al. Had shown that they found that the normal limits of AMH values based on the Gen 2 assay was about less than 4.7 nanograms per ml. And these are the group of women, normal women, and they have compared it to patients with PCOS. In our own data, where we collected data about 1,486 healthy volunteers with no specific medical history and normal pelvic ultrasound between 20 to 40 years. So we were looking at normal patients, and we found that the 75th percentile was 4.86 nanograms per ml, which is clinically significant, or it can act as an optimal cutoff value for diagnosis of PCOS. So we say in our population, if you get a level more than 4.9, which you go to 5 and over, probably the patient may have PCOS. Now coming to AMH and pathogenesis, the question is, do polycystic ovaries cause increased AMH secretion, or is it that the increased AMH leads to polycystic ovaries? So we all know that, we earlier thought that it could be a genetic cause only because we saw a lot of families where there was a clustering of many members in the family had PCOS, the women. But when they did the phenotypic studies, they found that I mean, this was based on the clinical appearance. But when they did the genomic studies, they found that less than 10% of disorders were through inheritance. So the other option is that it could be the intrauterine environment which may modify the endocrine and metabolic function of a child who is born to a PCOS mother independently from genetic inheritance. So if there is genetic inheritance, plus there is an intrauterine environment which is going to change the endocrine and metabolic function of a child, it will exaggerate the problem of PCOS in that child. In my studies, they've been found that when there is AMH is increased, it increases the LH secretion during pregnancy, and this causes increased PCOS-like features in the offspring of those mothers. Now, this has been shown in mice, and the also evidence is there that in vitro granulosa cells from patients who are anovulatory, PCOS patients who are anovulatory, they have higher AMH expression in the granulosa cells versus the ovulatory PCOS. And this could be an intrinsic granulosa cell dysfunction in the ovaries, which is causing the AMH to go up because they have AMH receptors present in the ovaries, and therefore, if there is extra AMH, it could cause polycystic ovaries. So there is a conflict on what is causing the problem because there are evidences in both areas. It's also found that this AMH receptor is present in human endometrium, in the placenta, and in the brain, in the gonadotrophin neurons. So AMH, when it is high, it modifies the GnRH neuron pulse frequency and alters the LH pulsatility, leading to PCOS in mice. So this has been very well demonstrated that AMH causes changes in the GnRH secretion and increases the LH secretion. So today, can we use AMH as a marker of ovarian reserve in PCOS women? A lot of us are using AMH as an identity to know whether, as a marker to know what is the amount of ovarian reserve in a PCOS woman or in a non-PCOS woman. And based on that, we make decisions on how to treat that patient. Now, here we'll see that there is a, at the age of around 44, you'll find that the levels of AMH come almost similar in the patients at that particular age. But we must remember that these data are from Western population, and in Indian women, we reach menopause almost 5 years earlier. And I think clinically we find that this kind of a pattern we see more at the age of 40 rather than at 44. So we need to be more aware of that, keeping in mind that we are treating Indian patients. So here we have a situation that it can be used, these ovarian reserve markers. When we have a PCO patient who's got a lot of eggs in her ovaries, we always feel that she's likely to get pregnant even when she grows older. But this study, when they compared PCOS versus non-PCOS women, and they followed them up for a certain time, they found that both of them have baseline ovarian reserve markers and age. Age is extremely important in determining the rate of decline of the eggs. And therefore, when we say that when you compare PCOS versus non-PCOS patients, you will find that they are dysfunctional. I mean, as the woman grows older in PCOS, she will find that the follicles are reducing, but at the same time, there is more of a normalization of her ovarian dysfunction. Her periods start getting regular, they start becoming normal, which we find very surprising, but this is the reason. But one thing is for sure, that the ovarian volume takes longer to reduce, and therefore the insulin resistance continues and the hyperinsulinemia continues as the patient gets older. And therefore we must keep in mind that a PCO patient, even if she's 40 and above, she's not going to get better pregnancy rates compared to a non-PCOS. So in our own data, what we found is we compared PCOS versus non-PCO patients, and they had the mean age and mean BMI, which was they were almost in the same range. There was no statistical significance between the two. But what we found is in the PCO patients who were less than 35 years of age, there was a statistical significant difference in the AMH values between the PCO patients and the non-PCOS patients. But after the age of 36, we found that there was definitely a lower level of AMH in the non-PCO patients, but it was not statistically significant. Similarly, when we looked at the ovarian volume under the age of 35, we found that the ovarian volume was statistically significantly high compared to non-PCO patients, whilst after the age of 36, even though the levels of PCO ovarian volume were higher than the non-PCO patients, but not statistically significant. So our cutoff seems to be more at an age of 35 rather than later. So AMH as a prognostic marker, can we use it to know how the ovaries are going to respond when we stimulate them during ovulation induction? And this very nice study with 976 PCO patients was done to compare at what really is going to happen when you have patients with different AMH levels. So they divided their patients into two groups, less than 4.6 nanograms and more than 4.6. And they found there was no difference between the FSH, BMI, the variables were taken care of in short. But when they compared group B, that is the ones who have a higher AMH than normal, they found that the response of the ovaries occurred at a higher dose than in the lower AMH. They also found that the total number of gonadotrophin ampules used was much higher, and hyperstimulation also was much higher compared to the low AMH group. So they concluded that the PCOS women with AMH more than 4.6 are resistant to HNG stimulation. They require a step-up dose during the ART cycles, and they're at a higher risk of severe hyperstimulation. Now, when we compare AMH and ART outcomes, what can we understand when we have AMH values? Can we say this woman will definitely get pregnant, or can we not say that? So this systematic review and meta-analysis was done, wherein there were 525 studies identified, out of which 19 were selected. And they put them into 3 groups of women who were undergoing IVF or ICSI in non-donor cycles. And they divided them into groups of normal ovarian reserve, diminished ovarian reserve, and high ovarian reserve, like as in PCO patients. Now here they found that the predictor of implantation and predictor of pregnancy, they compared all the 3 groups, and the results said that AMH has a weak association with implantation and clinical pregnancy rates in assisted reproduction. So even if you have a low AMH or a high AMH, you are not going to be able to predict that whether this patient will have at least a biochemical pregnancy or a clinical pregnancy when you're doing assisted reproduction. But it has a clinical utility in counseling women with diminished ovarian reserve, telling them that they have lesser number of eggs in their ovaries, and therefore the pregnancy rates will differ if ART is not done. And secondly, they will also be able to tell them that when we do assisted reproduction, it's not going to affect their pregnancy rates. So here we have looked at our own data with AMH and ART. And what we found is that in patients who were less than 35 years, there was a statistical significance in the comparison between PCOS and non-PCOS, as we say, in the AMH levels. And we found that the clinical pregnancy rates were were higher in the PCO patients, and the live birth rates were higher as compared to the non-PCO patients. Whilst if you see the patients between 35 to 37 years, again, the values are higher in the PCOS group, but not statistically significant. Whilst if you compare between 37 to 40 years, you find that the rates are almost similar. And, so by the age of 40, the PCO, non-PCOS become almost the same. So whether after 40, do PCOS women do better than non-PCOS women? Now, if you look at this data, less than 35, as I suggested to you, and this is more than 40, not much of a difference in the... So when we come to AMH as a marker of fetal hyperandrogenism, can we detect fetal hyperandrogenism? Now, today it has been shown that AMH levels which are increased in mothers who are PCOS can affect the babies which are in utero. So therefore, they have done studies in animal models where they have looked at gestational hyperandrogenism, where androgen levels were raised during pregnancy, and it has been shown that they have been able to induce PCOS-like female offspring in such animals. Now, the potential sources of fetal androgen excess is mainly from maternal androgens, and this causes increased female androgen levels too. Whilst if you go to see the AMH levels, they are all reported, besides the fetal androgens being, maternal androgens being increased, there is also maternal circulating levels of androgens, which has been shown that there is increased placental injury in those placentae. There is increased fetal hyperinsulinemia too, and fetal hyperandrogenism too. So all these are reported in PCO patients. It's also shown that umbilical cord androgens at birth may be raised in the PCOS offspring. Fetal androgen exposure at mid-pregnancy strongly influences offspring developmental, the programming of the fetus. And then it has been shown when there are increased levels of testosterone, which have been detected in amniotic fluid in PCOS women, has given rise to, with a ratio of more than 2:4 between PCOS and daughters, it has shown that it is definitely giving rise to higher chances of female offspring with PCOS. And this is enough to show that AMH in daughters of PCOS mothers versus controls, it's been seen that all stages of that female child, right from infancy till later, it has been shown that there is increased AMH, increased ovarian volume, increased insulin levels, increased testosterone levels, everything just as we see in adults. So this same sequence of metabolic abnormalities are also seen preceding hyperandrogenism in girls with premature puberty. So here we have to look at what really we need to take the message from here is that we have to make sure that children or girls who are young and who have got a mother who's PCOS also, we have to make sure that she's observed more often. She's looking for obesity, looking for any early signs of puberty, and we need to make sure that we do not, allow the child to become obese and allow the child to, sort of go into PCOS later on in life. So the take-home messages are that serum AMH is not a useful marker for diagnosing either polycystic ovaries, but it very well correlates with antral follicle count, with ovarian volume, and the PCOS phenotype. Insulin may contribute to increased AMH in PCOS, hence may need to be corrected. So when we have PCOS, of course, if the insulin levels are high, there may be high AMH. And therefore, when we have a high AMH, maybe we should suspect insulin resistance. Look for clinical signs of insulin resistance. If there's increased AMH exposure in pregnancy in PCOS, it can lead to hyperandrogenism in the fetus. And when there is a low AMH, we know that it predicts poor ovarian response and reduced pregnancy rates, spontaneous pregnancy rates. High AMH can predict resistance to gonadotrophin and clomiphene citrate stimulation. And therefore, when you have a patient with high AMH, you need to go slow on increasing your dose of HMG or FSH because they are slow to respond. But once the ovaries respond, they blow up if you go on increasing the dose. So you need to be very, very slow and go with smaller dose and gradually increase. It's a good marker for oocyte yield, or hyperstimulation and cycle cancellation, but not for pregnancy after IVF. It cannot predict viable pregnancies, and there is no single cutoff for AMH when pregnancy does not occur. And therefore, a note for all IVF or infertility specialists that it should never be used individually as a marker for withholding fertility treatment, because AMHs with a value of even less than 1 have conceived with the assisted reproduction. So I think we need to keep going and not only offering them egg donation. However, women should be adequately counseled that if there is AMH which is very low, then she may have to cancel her cycle, or if the AMH is very high, also she may have to cancel, or she may have to freeze her embryos. So fetal hyperandrogenism is possible due to increased AMH and may lead to PCOS in the offspring. And daughters of PCOS mothers are more likely to have raised AMH, LH, and ovarian volume at all stages of their lives. So I would like to, before closing, just announce this quizzes which is going on in the PCOS Society. We have started in August 15th and huge prizes to be won. So please log on to our website. And we have the second workshop. We did one workshop yesterday. We have a second workshop lined up on 19th September between 4 to 8 p.m. And so register for it and join us. Thank you so much for your kind attention.
Thank you so much,
Thank
madam,
you.
for excellent presentation. Now we'll go for the questions. Over to Dr. Sandhya.
Madam, that was an excellent presentation. Very, very informative. We have Dr. Abhijit Koshti with us. He would like to ask you a few questions.
Sure,
Dr. Abhijit, are you there?
I can see him. Yeah.
Yes.
Yeah, you, sir.
I'm hearing you. You're muted.
Abhijit, we can't hear you.
Abhijit sir, please unmute yourself.
Dr. You can
Unmute kara
unmute
sir.
yourself.
He's
Unmute.
Okay.
Yes.
Yes.
Yeah. First of all, Madam Duru Shah, on behalf of our Thane Obsgyn Society, we are really honored and privileged to have founder president of PCOS Society to enlighten us on the difficult subject of PCOS. I think we all have enjoyed and we have learned lot many things. Even after seeing and practicing for more than 25-30 years, we are yet to know so many things about PCOS. So thank you so much. There are some of the questions which I would like to take from the audience. So one of the participants have asked the question like, what should be the lifestyle modification for the thin lean PCOS? What is your opinion?
I think Dr. Rob Norman has very beautifully brought it out, what has to be done. And
Okay.
The only extra thing probably I would add is that the exercises which she would do, she also needs to do exercises, but she needs to do different kind of exercises. Like say, for example, she needs more of muscle building exercises, because that is the thing which will really help her to reduce her insulin resistance. Because we know lean patients also are insulin resistant, can be, I'm not saying all are, but can be. And therefore, we need to advise them accordingly. Most of the thin patients are we don't know what to tell them. Lose weight is what we tell the obese one. But when they're lean, we need to tell them to do muscle building exercise or resistance exercises, which will strengthen their muscles, because we know insulin also acts at the muscle.
Yeah, there is another question saying, what is the range of AMH in the adolescent age group to suggest PCOS?
Very difficult. I don't have that data. I'm not sure. I don't know if Rob has the data for adolescent girls' AMH values. I'm not sure about it. But usually AMH would be, as I presume, it would be very low earlier in a younger girl compared to an adult. And at puberty, everything starts getting activated. But I'm not sure what the median level of AMH in adolescent. Robert, do you have an answer to that?
So the AMH level during teenage years is not distinguishing PCOS from non-PCOS. So it's not worth measuring AMH until someone gets to about 2021.
Yeah.
So it's, and also we need to remind people it's not worth doing an ultrasound in adolescent girls for PCOS morphology, because up to 60% of normal girls are going to have polycystic ovary appearances. So the diagnosis of PCOS in adolescents does not depend on ultrasound or on AMH.
One last question I'm asking, what is the role of AMH in hypo?
In hypothalamic hypopituitary.
Pituitary.
Yeah, probably I think the AMH level should be normal, because here the situation is that there is no stimulation coming from the hypothalamus or the pituitary to the ovary, and therefore everything is in abeyance. But once the stimulation is given, everything should be okay. I don't think there is any issue on the AMH levels.
Okay, I think we are done with the questions which have been asked by the participants. There is a whole lot of panel discussion is waiting for you to answer. So I hand over the proceedings to Dr. Sandhya.
Sure.
Thank you so much, Dr. Koshti and Dr. Barmade, for chairing this session. Now we move on to our dynamic panel. We have our speakers with us. Yes, of course. I would like to introduce our panelists for today. We have with us Dr. Padmavathy Menon. She has been an undergraduate teacher for 41 years. She's been teaching at LTMMC and also has been the professor and head of department at GSMC and KEM Hospital. She has done 4 orations. She has papers to her credit, multiple publications. She has written chapters in 3 textbooks. She is also the chairman of the ethics committee at Jupiter and Hiranandani Hospital. She is practicing at these hospitals currently, and she has been the president of the Endocrinological Society of India from 2003 to 2004. Welcome, madam. We are really looking forward to your presence here to give us a take on the endocrinological aspects of PCOS. Our next panelist, thank you, ma'am. Our next panelist, Dr. Neelima Shilotri. She has 35 years of experience. She has been a UG and a PG teaching professor at the Rajiv Gandhi Medical College and Kalwa Hospital. Her hobbies, she's mentioned, are traveling and cooking. She is a great cook, so someday we all hope to go and taste her food. Her special interests are high-risk pregnancy, infertility, and vaginal surgeries. Welcome, madam. We have with us Dr. Alaka Godbole. She is practicing at Akshay Nursing Home and is also attached to Jupiter Hiranandani Hospital. Madam is a very senior and experienced gynecologist, and she has a lot to tell us about myoinositols. So we would like to hear it from her later on during the panel discussion. Welcome, madam. Thank you. We have a young and dynamic infertility expert with us, Dr. Rachana Deshpande. She is at the Infinity Research Center. She's done her MD from the JJ Group of Hospitals. She has done her FICOG in reproductive medicine from Kolhapur. And she's also trained in ultrasound and hysteroscopy and laparoscopy. Welcome, Dr. Rachana. Ma'am. We have with us, we call her the Bhivandi Queen. She is Dr. Supriya Arwari from KEM Wadia, MD, and she is practicing at Supreme Hospital, Bhivandi. She has 20 years practicing experience. She's the joint treasurer of the TOGS, and she's chairperson of the Adolescent Health Committee of TOGS as well as AMOGS. She is the past president of IMA Bhivandi. She has recently won the Iron Lady Award at a beauty pageant held called Medi Queen. So I welcome our Bhivandi Queen, Dr. Supriya Arwari, and hosting this panel discussion is myself. I have already been introduced, so without much ado, we should go on to the panel. Our first slide, as we know, is tip of the iceberg. So we go on to our presentation. I shall share my screen now. In between, why are we having this panel discussion? It is seen that polycystic ovarian syndrome is a heterogeneous endocrine and metabolic disorder which has diverse features such as reproductive, that is infertility, pregnancy complications, metabolic features of insulin resistance, metabolic syndrome, pre-diabetes, diabetes, and cardiovascular risk factors. It is like a Pandora's box, which once opened can create havoc. So we have a multidisciplinary approach to tackle this disorder, and we have this panel with experienced gynecologists and stalwarts in the field of PCOS. In our Indian context, we have to our rescue the team of Bahubali 2 to pave the way forward, overcoming all these obstacles of insulin resistance, hyperandrogenism, hormonal imbalances, metabolic syndrome, and psychological problems. So we go on to our first case, that is a 34-year-old lady. I hope it is on the screen now. Can we all see the slide?
Yes.
Yes.
Yes. So she is a 34-year-old lady, 58 kilograms in weight, married since 5 years, a known case of PCOS with irregular cycles, trying to conceive since 2 years, an investment banker by profession, on treatment for hypothyroidism for the past 10 years, but her TSH level right now is 9. And she has had 2 failed IUI cycles with clomiphene 4 months back. Her HbA1c and AMH levels then were optimal. She is desperate to conceive within the next 6 months. The investment bankers always have a timeline. Her sonography shows the normal uterus. The left ovarian volume is 18 cc's and the right one is 20 cc's. She has galactoria for which no treatment has been given. There is no male factor involved. Now I would like to start with the youngest panelist, Dr. Rachana Deshpande. What investigations would you like to do in this case? See, we all have a panel in most of the hospitals. The lab says this is my panel package. So choose from here. So you have to decide whether you would like to customize it or choose accordingly. So treat this patient from your point of view.
In this case, since she's 34-year-old with this previous history, I would like to investigate for TSH and free thyroxine level and correct her thyroid levels. Because she has galactoria, her serum prolactin should also be investigated in this case. And serum AMH as a baseline has been done, so no need to repeat. Also, I would like to confirm if tubal patency has been confirmed because she has had 2 failed IUIs, but tubal patency has not been mentioned. I wouldn't like to do the whole androgen panel as of now. Primarily, she should be investigated for these because there is not much role of FSH, LH or other androgen panels at this stage.
Okay, fine. So we move on to our endocrinologist, Dr. Padma Menon. Madam, my question to you is regarding her hypothyroid state. Now, her level is 9, as we have seen. So how would you like to, now she's been sent to you by the gynecologist that first you go and get this corrected. So how would you like to approach this patient?
First, her thyroid level should be corrected to a TSH value of less than 2.5 or less. Lower is okay, higher is not okay. As she is already on treatment, I would check her TSH because it is now 4 months. And if the TSH is normal, it is okay. The second fact I would look at, you told me that she was diabetes is well controlled. So we would look at serum prolactin and check, confirm that diabetes is well controlled. Now, hypothyroidism can result in infertility, but not these levels. 9 is too low. Normally, it doesn't interfere, but when it is abnormal, we presume that it may interfere. And hence, before treatment of fertility, we need to address serum prolactin. Now, high prolactin can be due to microprolactinemia, primary hypothyroidism, drugs, pregnancy, chronic renal failure, cirrhosis of liver, chest wall injury, breast stimulation, and last but not the least, a macroprolactin in the serum. Now, many laboratories don't do this. So you have to make sure that when you get a value, you need to make sure that the second step is done, that is PG extraction by the lab, and the monomeric and correct PRL level should be informed to us. If that PRL is normal, she's not on drugs and everything is okay, then the prolactin doesn't require treatment. Now, macroprolactin is estimated to be about 11% in those with Rotterdam criteria. And this is assayed as a serum, as a bias, and hence PRL level may not be necessary to treat. Now, there are certain machines and the RIA kits which give this macroprolactin is included. So we need to mention that this need to be ruled out. For example, in India, SRL and Metropolis gives you fairly accurate. Metropolis gives you the macroprolactin level, so you're sure that macroprolactin is not being treated. So that is necessary. And once the high PRL is there, you should treat it. And if the PRL is normal, and is there an association between prolactin level and PCOS? In the earlier studies, it was suggested, a link was suggested, but when all the above causes were ruled out and proper prototype criteria was taken into consideration, there doesn't seem to be a relation between prolactin level and PCOS. Anything else you want to know?
Yes, madam. One more thing is, do we do antibody levels for thyroid in these patients, or we just treat it as per the TSH levels?
Usually antibody levels are, what do antibody levels mean? Endocrinologists fairly believe that these antibodies do not interfere with the pregnancy. But what we believe is that presence of antibodies in the blood suggests that there may be other antibodies at present, not diagnosed, not known, which may be interfering with the pregnancy. So antibodies, thyroid antibodies interfering with pregnancy is extremely rare. The high level suggests that there are other multiple antibodies which may be really interfering with pregnancy. And what these antibodies are, they are being evaluated.
Okay, so madam, you said the level should be ideally 2.5.
Yes.
Before, Madam Duru Shah, would you like to tell us that in this patient, do we wait for the levels to come down to 2.5, or do we start her on treatment before that? And one more thing is, suppose her prolactin levels are normal, would you still like to treat the galactoria?
If I'm treating for infertility, first of all, yes, I want the TSH level to be less than 2.5. The reason is that if the TSH levels are higher, it has been shown, it does definitely come in the way of either causes some luteal phase deficiency, or it may cause problems with conceiving, or it may cause problems with early miscarriages. Not that even if she conceives. So in short, we want to bring her thyroid back to less than 2.5, that's one. Thyroid antibodies I like to do because if they are positive, then in pregnancy we would like to give them maybe a low dose aspirin to prevent antibodies causing any effects on the fetus. And the third thing is that if she does have galactoria, the prolactin is normal, but there has been a recommendation that if there is galactoria and if prolactin is normal, but even the TSH has to be normal, because galactoria can occur because of even hypothyroidism. So first I would correct the hypothyroidism. I would wait. I wouldn't treat her till then. I would wait till, which is because we can bring down the thyroid very quickly. Thyroid and prolactin very quickly, within 6 weeks or so, we are able to control it. And then once we control it, and if the galactoria is still persisting, then in that case, and prolactin is normal, there is a recommendation that we should start a small dose of Godbole. So, but then we have to be sure that this galactoria is not because of, I think a lot of patients who have galactoria, which we want examination demonstrate. They didn't even know they had galactoria. But once they've seen that happening, then they keep checking it themselves. And they keep checking it and they keep checking it, and then the galactoria just becomes sort of permanent. So we need to tell them not to keep checking and stop manipulating the breast and then do the prolactin. I think if the galactoria, if there is no prolactin, increased prolactin or hypothyroidism, and you give them even a small dose of Godbole, the galactoria disappears.
Great. Now, I would like to ask Dr. Alaka Godbole, madam. Madam, this patient comes to you. Now, she has come to you after 4 months of having failed IUIs. What would be your approach to this patient? Dr. Godbole?
Yes. Am I audible?
Yes, madam.
If she comes after 4 months with normal thyroid and prolactin levels, then I like to advise her mainly for normal menses, that is by inducing ovulation-inducing drugs like clomiphene plus metformin, and then if it doesn't come to normal, it never comes to normal, then please go to IVF specialist. That will be my advice, because if she is in hurry, and as Dr. Duru Shah madam just now told that AMH and age is very much sensitive. So as such, she's 34. She is in a hurry to get pregnant. So I will advise her first 2 cycles, and then I'll advise her to try again to go for ART specialist.
Okay. Okay, Madam Neelima Shilotri, how would you approach this patient? Would you like, suppose she has not got any diagnostic procedure done before, like a tubal patency test or a hysterolaparoscopy? Would you like to take her for these procedures before you start her on the cycles again, or like a different approach in this?
Yeah, we would like to have a fresh look. At the case. First, we have to, even though it is said that the male factor is normal, we like to repeat her semen, find patient first semen, find out.
Madam, louder.
Why do IUI attempts have failed? We can have a laparohisto to find out whether the previous IUIs have done some damage as the one has failed. And after correcting her TSH and prolactin, because 2 cycles of ovulation with letrozole, allay her anxiety first of all. Tell her that she doesn't have to catch some bus or flight or something like that.
Okay, Madam, we could not hear you very well. So just correct your.
Is it okay?
Yes. In the meanwhile, I would like to.
Okay?
Yes, Madam.
Is it okay now?
Now it's better. Yes, it's much better. Yes.
Yeah, first you have to allay the anxiety that she doesn't have to catch any flight. Repeat the male factor, semen report, detailed semen report. Do quick laparohisto to find out whether previous IUIs have done any damage, treat any infection caused by previous IUIs, correct hormonal factors like TSH, prolactin, etc., hyperprolactinemia, etc. Have a fresh outlook on the case and then decide the further approach. Then allay her anxiety first of all. Tell her to relax. She will conceive. So kindly give her supportive advice, good dietary advice, advise her some pranayama, yoga or some such thing. Because of anxiety, many times they don't conceive. It's the hypothalamus where they conceive first and then they conceive in the uterus.
Okay,
am I audible
fine.
now this time?
Yes. We got the message very loud and clear. It's the hypothalamus where the conception happens.
The conception happens first and then in the uterus.
That is the tag.
Thank you.
Okay. I would like to ask our Bhiwandi Queen, Dr. Supriya Arwari. Now, this patient is staying very far from Mumbai, and she is tired of traveling there, and she says, why go so far? So why don't I try someone who's close home? So what would you do if she comes to you? Very, very briefly. Unmute. I had told her to keep herself muted. Thank you.
At the outset, I would like to thank the organizers for including me in this August panel. And I must say that after Dr. Norman and Dr. Duru Shah's talk, me speaking on this panel is like a student speaking on a panel after principals and professors have given their talk. So let me just take a bow to both our speakers today. And Madam, if I may add so, with all the talk of AMH and what a PCO mother can do to her offsprings, I remember Diwar movie. So instead of writing on the hand, Mera baap chor hai, we should start writing Meri maa PCO hai. So coming to your question, Sandhya, if she is a female investment banker, it is very unlikely that she has anything to do with Bhiwandi. But if at all, I belong to a small town with resources which are limited. Since she's in a rush to get pregnant, she's only married 2 years. She has had only 2 cycles of IUI. We can recommend another 3 to 4 cycles of IUI. IUI up to 6 cycles we can try. And I would also like to add on to what Neelima madam said, ki sometimes just putting them off treatment can help many patients to conceive, what we call as a rebound phenomenon. You just stop the treatment, their anxiety is gone, the hormones come back to where they should, and often I've seen these patients conceive in 2 or 3 months. Usually, in fact, I tell them to take a vacation and just go somewhere where they don't have work and doctors and home pressures and try for a pregnancy. If she's obese, she can take a chance in these 3 months to lose some weight. That's my opinion.
Okay. So I think Dr. Supriya believes in take a break and then maybe you will make the break. So I would like Dr. Robert Norman, sir, would you just tell us as to what is your take on this case, and also the delegates want to know what is the right time to do AMH and prolactin levels.
So there's quite a lot of information missing from the history. So we're not told whether she's having regular cycles or not. If she's anovulatory, then at least 6 months of oral ovulation drugs with documented ovulation would be essential. And the chance of getting pregnant is very high. If she's ovulating, then in our experience, doing a lot of IUI cycles is a waste of time. We would do maybe 2 or 3 maximum. And then after that, if that hasn't worked, IUI is probably not going to work. The history said something about she's had failed IUI cycles. Now, people fail for 2 reasons. One is they don't get pregnant, in which case you want to move on to something else. Or they fail because they don't ovulate, in which case you need to spend some time sorting that out. I think it's important for everybody to realize that there is absolutely no point giving clomiphene month after month to someone who's got unexplained infertility who's ovulating. There's no evidence that you get any benefit from that at all. I think in this patient, I would do an FSH, LH, and either a measure of estradiol directly or looking at the endometrial thickness for estrogen biological activity. I think the LH and FSH will give you some idea of whether there's a significant hypothalamic problem. And of course, we need to also recognize that premature ovarian insufficiency can happen in a woman of this age. It seems to me if she's been trying for 2 years and she's been ovulating and she's had 2 cycles of IUI, that really I agree with everybody that she should move to IVF. She's an investment banker, she can afford it. And the only reason in this patient to measure AMH is to make sure that you don't give too much gonadotrophins on an IVF cycle. But ultimately, this patient probably will end up with IVF. She can afford it, so I would encourage you to put back 1 embryo. I know that's not a popular message in India. And the one really good trial on PCOS and IVF suggests that doing a freeze-all cycle and putting back an embryo on an artificial cycle gives you a higher pregnancy rate. Thank you.
Thank you so much, sir. That was a very well compiled answer, and I think all our delegates are quite satisfied now as to the road ahead. We move on to the second case. I'll just share my screen. This is a 16-year-old obese girl. She is having a BMI of 32. Before that, I'll just show the algorithm of the treatment for infertility as Sir has summarized it. And then we move on to the next case. Slide 26. Now this girl is 16 years of age and she has a BMI of 32. She is having secondary amenorrhea for the past 6 months. She has had 2 cycles since attaining menarche at the age of 15 years. On examination, she has acanthosis nigricans as well as hirsutism. She has tried many diets but is unable to lose weight. Now, this patient is a challenging case for us because she is an adolescent PCO, and we would also like to know the differential diagnosis in this patient, the management plan, counseling, and the cosmetic concerns. I would start my questions with Dr. Menon. Madam, now this patient is presented to us and the mother brings her and she is very worried. So how would you, first of all, start with your investigations and what management plan would you recommend?
Number one, it was already brought out by Dr. Norman that when your menarche is late, 2 to 3 years, you may not have regular cycles. So she could be one in that group. But what worries about her is obesity, presence of acanthosis and hirsutism. Obesity itself can, to some extent, cause these problems. I would have liked to know the family history of diabetes or PCOS. Then I would say that she is possibly on to become PCOS. What investigation will I do? I will certainly rule out diabetes, and along with that, because we have seen patients like this coming with impaired glucose tolerance or diabetes itself. And we also would like to do the testosterone and prolactin level. Prolactin is a routine whenever they have secondary amenorrhea type of thing, just to make sure that we have ruled out that. Apart from that, other endocrinological problem come into mind, and at this age, we will suspect Cushing syndrome. We would like to rule out Cushing syndrome and severe hypothyroidism. As she's got cycle, that means thyroid function test would be done. Clinically examining for Cushing syndrome sometimes may not help. I may have to do a dexamethasone suppression test and make sure that she does not have a Cushing syndrome. Then, so what, would you like to go to management now, or this is sufficient?
Madam, regarding the testosterone levels, because there has been a lot of talk, there is a lot of confusion regarding free, total, calculated, and and also about insulin resistance, because a lot of people are saying, what are the exact serum insulin levels and tests, what you would recommend in this patient?
We as endocrinologists do not believe in doing insulin levels because we cannot do anything with that insulin level. Anybody who puts on weight, for example, if I am 58 kg and I become 64, I have become more insulin resistant. Here she is obese with a BMI of 32. So she is insulin resistant. Doing an insulin resistance test or insulin level is not going to add to that. We will consider her as insulin resistance. Number two, she has acanthosis nigricans and hirsutism. So we will do a testosterone. Mainly we do testosterone levels in endocrinology sometimes because we would make sure that we don't want to miss a tumor which is producing testosterone, which is going to go up over a period of time. So we would want to rule out that it is not very high. Testosterone by itself has a lot of problem. It should be done early in the morning. It should be done fasting. It should be done, if necessary, once or twice, because the correct method of doing testosterone level is LCMS-MS, which is costly and is not being done. But I understand that there are certain newer methodologies which are coming. This might solve the problem. So we can do an SHBG as Dr. Norman suggested. That will give you some idea about both. But finally, just a free total testosterone is done. Now, free testosterone is worst test because it has a lot of problems in terms of laboratory evaluation, and hence it is not going to add anything to it. We already said that USG may not help at this age because PCOS like ovaries can be seen. So coming to that, my main point would be after making sure she has no diabetes, FSH is normal and all that, would be to put her totally on diet. Now diet, yes, motivation is the main factor which may have been absent. So we look at it whether she has been motivated enough to do that. And when I talk about diet to 15 or even younger girls, I feel that even the whole family needs to be treated because it is the pattern of diet at home that needs to be changed. And everybody has to pitch in with her to go on a diet that she is eating so that she's not tempted. And there are so many other ways which we do that and that we need to do that. So those are the things. So if necessary, we would rule out a Cushing syndrome by doing a dexamethasone suppression test. So obesity is the first thing that needs management. Otherwise, she's going to come back to you with diabetes, PCOS and obesity later on in life. She's only 16. She has yet to get married and all those things. There are drugs can be given for obesity. Unfortunately, most of the drugs have side effects, and orlistat has been mentioned as a thing. But for orlistat to function, you have to have some amount of fat in their diet. And hence orlistat, and many a times my patients don't tolerate orlistat well, especially because of the oil leakage. Whether in a 16-year-old we should suggest bariatric surgery or think about bariatric surgery is another matter. That is another talk altogether. But GLP-1 has been another drug which is used abroad to manage the obesity. We do not have that at the moment, and it is not recommended by our FDA to give GLP-1 agonist for obesity. Okay.
Excellent, madam. Thank you so much. That I think has really resolved a lot of our doubts. I would like to ask Madam Neelima Shilotri about the role of ultrasound in these patients, and what do the guidelines say about the ultrasound in PCOS?
Yeah, in PCO, see, there are two things in ultrasound of this child. One thing is to confirm the PCO that more than 12 follicles, the volume of the ovaries more than these things. But he has had cycles and she has stopped. So they have small mechanical also, like partially some such thing. So we must confirm as per the criteria, Rotterdam criteria, that has PCOS and other tract anomalies as well. Considering her phenotypical issues, she fits more into PCOS. And regarding as rightly as Madam Padmavathy said, the diet and exercise issues, they have to consider their brains because and if the family also becomes very strict to them and they just follow the diet exercise religiously, they all like a phoenix, a very beautiful, which I have seen in younger daughters.
Madam, your voice is quite garbled.
It is not at all difficult to manage with diet and exercise. So it must be followed that way only. I am on my mobile, so it may be because of that. Am I audible now?
Madam, very, very less.
Achha. Am I audible now?
Yes, now you are audible.
Yeah. So I think with diet and exercise, I don't think it is very difficult to manage. Anti-obesity drugs, I do not advocate at all. USG is important for two things. She has had 2 cycles and gone into secondary amenorrhea. So minor tract anomalies as well as ultrasound criteria for PCOS or criteria like more than 10 or 12 follicles or more than 6 all that confirmed for PCOS, but phenotypically, whatever description you have given, she fits more into PCOS, and the further progression must be avoided into a frank, full-blown PCOS by good diet and exercise. It must be drilled into the parents and grandparents that they can avoid further complications.
Okay, thank you,
ma'am. Body shaming should not be done by the parents or sisters, brothers, and all that.
Okay, thank you,
we
madam.
have got so many celebrities who have evolved into very beautiful women just because they followed a very strict schedule. So in that, I am with Dr. Padma Menon.
Okay.
Thank you.
Great, madam. Thank you. Dr. Alaka Godbole, madam, what would be your take? What is the line of therapy you would suggest in this patient? And how would you counsel her? And would you involve a nutritionist in this patient? Or would you send her for any psychological counseling also? Because she has shown inability to lose weight. Or would you like to do it all yourself? So I would like to know what is your management plan?
Yes. Firstly, I will counsel her about weight management. But as such, you have mentioned that she has been counseled for lifestyle management and weight management She is unable to lose her weight. That is very true. And that is mainly her hormonal issue. So first I'll try to correct her menses, because she is having hardly twice she has menstruated in last year. Only 1 year has been passed after her menarche. And as per the new guidelines of ICEBERG 2018, as you have mentioned, whenever she has started within 3 years of menarche, she should not be investigated for a lot of investigations, because we can see as such she is having obesity, quite a large BMI, more than 32. So we have to see first about that, and we have to correct by giving her combined oral contraceptive pills containing CPA, cyproterone acetate. That will help her a lot. And second thing, even though she's not having insulin levels done or not done, or she's having history or not, family history of diabetes, I like to try her for first metformin. But what happens, as per my this thing knowledge and in my practice, whenever I advise to take metformin, these girls ask, oh, this is the drug which my daddy is taking or my mummy is taking for diabetes. So better not to give metformin for such patients. I'm generally giving inositol tablets, or means capsules or powder. Powder is more effective in such patients, and they are ready to take because they don't like to exercise every day. Whenever we counsel her, counseling is the crux of the treatment in such patients. So with me, I will like to involve dietitian also and psychologist also, but first is dietitian, because these ladies or girls may say, they are ready to consult dietitians more than us, because they are not interested in getting menses regularly. Only their mothers are interested in getting menses regularly for them.
Right. Thank you, madam. So that was a very different kind of a take. And as we all wanted to hear about your experience with myo-inositols, we all know you're a strong proponent of the same. So that was a good message which you have given us. Dr. Norman, I would like, since you've already taken a talk on the obesity and PCOS with us, but now there has been a lot of revision in the guidelines. There has been changes in the last couple of years. So I would like you to tell us exactly how you would like to approach this patient in your practice.
So first of all, I'd like to commend Dr. Padma Menon's answer. I think that was a very important one, because we need to remember that medical conditions can occur in teenagers that we attribute to reproductive conditions. I would want to know about her family. If all her family are quite thin and she's very overweight, then she definitely needs more extensive investigation. If the family was quite heavy, then it's likely to be much more environmental and lifestyle that needs to be looked at. We need to remember a patient like this does need to have a GTT and lipids done. She's got a very high risk of diabetes. And we also need to recognize that young women like this have a high risk of endometrial cancer later in life. And I've seen endometrial cancer at 24, and I'm sure some of you have seen it even earlier than that. So these are the risk factors that we need to look at. I don't think that ultrasound or AMH is necessary in this patient. She almost certainly is going to have PCOS when she's in her 20s. And therefore, I think I'd spend a lot of my time giving reassurance that even though she was having irregular cycles, they may well come back to normal. Or if they don't come back to normal, we've got very good therapies to enable her to get pregnant. So we know from statistics that the patients with PCOS have exactly the same chance of having a baby as anyone else. It just means that it takes time and is more complicated. So what the guidelines would say is that you need to exclude other conditions such as thyroid and Cushing's. I think this is not likely to be a congenital adrenal hyperplasia. And then once you've done that, then I think you really do need to talk with the family about education with diet, exercise, reassurance, etc. But these are problems. I mean, I probably see more of them than you do, although I'm sure you see quite a lot as well. But very overweight teenagers with irregular cycles, we're going to see a lot more of.
Yes.
Thank you.
Thank you, sir. Madam Duru Shah, there are a lot of questions as to the role of vitamin D in these patients. Do they help? Vitamin B12 levels, vitamin D in these girls, do you recommend that? And also the mother always says, but she hardly eats anything. So as we all know, diet, exercise play a very important role, but do you also think depression plays a role in this case?
There are many questions together. I think I'll try and answer all one by one. Where it comes to vitamin B12 and D, if a girl is on metformin treatment, then yes, we need to supplement her with vitamin B12 because they are known to develop deficiency of vitamin B12 when they are on metformin. So that's one thing we need to do. Where vitamin D is concerned, in PCO patients, it's been found that there has been some amount of higher amount of vitamin D deficiency in those girls or women. In our country, we tend to have a lot of vitamin D deficiency. I mean, every woman who I test is deficient. So it's very difficult for me to tell you whether, I'm seeing more of vitamin D deficiency because it's like everyone seems to be having low vitamin D. So whether the standards of vitamin D or the levels of vitamin D in Indian women is different, but though we have so much of sunlight, we have, there's no need for us to have deficiency, but we do have it based on the current standards. So I think vitamin D you would give anyway. If there is a deficiency, you would give. Vitamin B12, if you're giving metformin. And then in an obese young girl who's got irregular periods and she's having evidence, say, of, even if she has just obesity, I have found that giving them metformin helps me in helping them to, not that the metformin helps them to lose weight, but it helps them to probably, it increases their insulin sensitivity, and therefore if they exercise, they lose weight better. Most of the girls I know who you tell them, please exercise, we put them onto different programs, but they get so frustrated. They say, my friend and me, we do the same amount of exercise. And why am I not losing weight? And then I go through their diet to find what they're eating. I know the number of calories they're consuming is quite within the norms, but still they have difficulty losing weight. And you add a little bit of metformin, and I think it helps them quite a bit. So I do like to give obese young girls who have got irregular periods a little bit of metformin, and that really helps them and encourages them when they exercise. I don't give it to them if they're not exercising because then it doesn't help. Coming to the next part is where the depression is concerned. Yes, every young girl who's obese or who has hirsutism or who has, acne is likely to be emotionally disturbed because, she's at that age when she wants boys to look at her, when she wants to be attractive. And all this comes in the way. And I've had young girls who don't want to go out. They just stay at home because I know this lockdown period must be helping them tremendously, but at the same time, they don't want to socialize because they feel very upset when they are not, they feel very upset only because of their body image. So in short, counseling will help them, not antidepressants. Counseling will help them. A lot of counseling really helps them, and I think if we as their physicians encourage them and give them examples of how weight loss can help. So all my patients who have have been very much helped by weight loss, I make them the peer educators in terms of telling them that if I have a young girl who needs to talk to somebody, can I put her onto you? And if they agree, then I connect the two, and it helps them a lot in getting that enthusiasm and support, because you have the picture of the girl who's earlier before her weight loss and how she looks now, and all the acanthosis is lost, her skin has cleared up, this acne has disappeared. I mean, it does dramatic changes. So I am in a bit of a, I like to use metformin when I need to. I do use it, and it helps our patients quite a bit, especially only the ones who are exercising, not the otherwise. So exercise and diet both need to go hand in hand, and we have to tell them that this is this is everyone's lifestyle as it should be. Whether you're slim, whether you're obese, whether you're young, whether you're old, don't say that you'll exercise only when you get old. You have to start exercising right from younger days and carry it out throughout your life. And it doesn't mean it's only for PCO patients, it's for everyone. And I tell them, see, I don't have PCOS, but I'm still exercising. I said, at my age, I exercise, why can't you? And I try and encourage them, and it works well, very well.
Excellent, madam. So that was a very motivating message. And we should all remember this, not only the girls, even the boys, the men, everybody should exercise. That's very important. Now we go on to the cosmetic concerns in this case. I would like to ask our beautiful, dynamic, young gynecologist, Dr. Rachana Deshpande. Now this girl says, I want a quick fix. I want to go to college. I have a prom. And so what cosmetic concerns, how would you handle her?
Hello everybody. A lot has been spoken about obesity. I would like to also look into hirsutism. First is grade the hirsutism. How much is the hirsutism by the modified Ferriman-Gallwey score. Also important to find out terminal hair. Terminal hair is usually the one which grows more than 0.5 centimeter, that is 5 mm, and is pigmented. So to actually see where all that growth pattern is. And then for cosmetics, there is a huge range, but usually the affording people go for laser treatment. In laser treatment, it is important to make them understand the skin specialists usually do it, but laser is just a reduction. It is not something that is going to completely eliminate that hair, especially for the upper lip and chin. They may also need high wavelength lasers like Nd:YAG, and it may also be required for multiple sessions. And along with laser, OC pills, if she's already taken that, if the diet is not acting, if the exercise is not acting, then anti-androgens can also be added. There are also certain creams like eflorbitin is coming, so that makes the hair stay in the telogen, that is the shedding phase, for longer and reduces the anagen. But these are all temporarily. Ultimately, till the hyperandrogenism is not corrected, all this will come back. They will again have hair growth on the chin, on the beard area. So it is important to address the cosmetic issue, but at the same time correct it through reducing her weight and management of the hyperandrogenism. Another thing, if laser is not affordable, there is a pool, right from plucking to waxing to depilating creams to shaving. So important is that the period between the two sessions which changes. So shaving, she's going to require more often shaving. Some people feel that they'll get thicker hair growth post that. Depilating cream, some people get reactions. Waxing, some people get folliculitis. So individualization, some mode of all of this which is easier for her, and to adopt that for her, which will really make a lot of difference, because hirsutism is really depressive, and it affects the behavioral, it requires a lot of behavioral therapy, counseling, and important is scoring. And also in hirsutism, it is important to tell them that it requires at least 3 to 6 months of treatment to actually see any effect. It's not like 1 month the treatment is taken and the hirsutism will disappear. It will not.
Great. So that was very nice. Just a word of caution, I would say, because we do, there is a lot of talk about laser hair reduction, but by and large, most of the dermatologists always recommended, they say, let her wait till at least she's 20, 21, because, you know, that is the time when they say that it should be really being done. Same like as we say in bariatric surgery, there's no quick fix. It is very effective, but then we have to choose the cases carefully. The teenagers are always in a hurry. They say, but why not go for that? So we have to be very careful in these patients. I would like to ask Dr. Supriya Arwari. She leads by example. She's lost 25 to 30 kgs of her own. So I would like to hear it from her as to how she can do it and what is her message to those who say that they cannot lose weight.
Thank you, Sandhya. First, just a couple of points. Now, she is only 16 and she is only a year after menarche. So, as per the current guidelines, any girl who is less than 2 years since menarche, we will be very cautious while labeling her as a PCO. It can just be a maturing hypothalamic pituitary axis, and it is likely that in a year or two, means 2 or 3 years since menarche, she is likely to have regular menses later on. Here again, the family history is going to be very important. A word of caution about ultrasound. According to the latest guidelines, we need to wait at least 8 years after menarche for a proper PCO kind of picture to come up on ultrasound. However, I would still recommend an ultrasound on this girl. Like all the previous panelists said, we would like to rule out ovarian tumors. We would like to rule out adrenal gland tumors. We would like to rule out a pregnancy. Please note, 16-year-old does not exclude a pregnancy. So if she's amenorrheic, please be vigilant for a pregnancy in a young girl. Now coming to the topic of weight loss, so close to my heart. And my tagline is the difference between FAT fat to FIT fit is the word I. Unless she is self-motivated, she's not going to lose the motapa. So it is very important that the girl herself feels motivated to lose weight, and that of course will come through counseling, through giving her the good advantages that she will face with losing weight. And like sir said, if we can stress on the fact that she is more prone to diabetes, she is more prone to endometrial cancers in future, it will probably act as an impetus for her to lose weight. Now, what common tips that I give, what I have done myself, because it's easier said than done, really. When losing weight, it is the easiest thing for the lean people to say, please lose weight. And as an obese person, you always feel so victimized that, oh, everybody thinks I am to blame for my weight gain. The first and foremost thing that we should ask them to do is keep a logbook. All the mothers and the girls will say, ये कुछ खाती ही नहीं है, फिर भी मोटी होती है. Now that is a total humbug fact. You ask them to keep a log because people only count what they ate during lunch, dinner, and maybe breakfast. They coolly neglect what they are eating between meals, and that is what can be a big contributor to the calories. So ask them to keep a daily log. So at the end of the day, they themselves realize what rubbish they are eating throughout the day. Give them the adage, very age-old adage, that eat breakfast like a king, lunch like a commoner, and dinner like a pauper. In between meals, the food that they are consuming between meals should be strictly low-calorie food, like salads, like low glycemic index fruits. In the regular diet, they should include a lot of naturally colorful stuff like vegetables, like salads, like fruits, like nuts. These usually will not give them lots of calories. The aim should be to keep the calorie restriction around 800 to 1000 kilocalories per day, and distributed, of course, over 3 or 4 meals. They should be keeping a low carb diet, a medium fat diet, and a high protein diet because they don't want to lose muscle mass. Exercise extremely important. They cannot lose weight just by dieting. Of course, dieting is a big part of it, but exercise is very important. Now, for exercise, the minimum time that I would recommend is 45 minutes. It can be brisk walking, it can be cycling, it can be jogging, any good aerobic exercise, Now, the first excuse they come up with is, I don't have a gym close to my house, I don't have the time to go to the gym. So being a schoolgirl, you give us simple tips like start walking to school, go walking to school. If you have to travel a long distance, get down one bus stop earlier and walk to your school. So she walks for 30 minutes to 45 minutes to school. That just sorts out her daily quota of exercise. About exercise, why this figure of 40-45 minutes have come up, I'm sure most of you are aware. I came to know very late. So I would like to just tell you why this figure has come. When you start exercising, the first 20 minutes, your body is spending the ready glucose that is circulating in your blood. The one that you have just recently had your meals, and whatever sugar is circulating in your body, that will be utilized for the first 20 months. Now you want to lose weight, you want to convert the fat that is stored with you into glucose and burn it. For that, you have to wait those 20 minutes, let the body burn the ready circulating sugar, then the body will start converting the fat to glucose and start spending that. So if this exercise less than 20 minutes, it's absolutely of no use to lose weight. It's okay if they just want to maintain fitness. To lose weight, 40-45 minutes is the minimum time that they need to exercise. And the key is persistence. People come back in 3 months saying, oh, I can't lose weight. You tell them you have to do it for a year, for 2 years, keep consistently losing weight. Give them a target, 10% of their body, what a current weight, they should try to lose over the next 6 months. If you give a target, it works better. You tell them randomly, jao vajan kam karo, they are not going to do it. Give them a target that I'll see you after a month. I want you to lose 1 kg per week and come back with within 4 weeks with either 3 or 4 kg weight loss. That works much better. Persistence is what we need to convey. Baba, bacha, tum continue karo. Do it for a long period of time. You'll surely lose weight.
Great. Supriya, so that was awesome. That was a really, really all-encompassing modality for weight loss. So if you can see my screen, I have just shared a small slide.
Absolutely.
The
My
only
favorite
thing,
minions.
the only thing that is thin over here is the diet and weight loss title. So this is hopefully the kind of diet which they can all do. And
Totally.
so these are the kind of creams which people try, and this is the algorithm for the hirsutism treatment. Now we go on to case number 3. She is a 48-year-old, 80 kgs diabetic woman on antihypertensives and antidiabetics for the past 8 years, having irregular bleeding PV for the past 8 months. Her cycles are heavy, lasting for 3 to 4 days at a frequency between 18 to 35 days with severe abdominal pain. Her pap smear is normal. Sonography shows adenomyotic uterus with endometrial thickness of 16 millimeters. I would like very, very, very concise and quick answers from all our panelists. I would start with Dr. Duru Shah, madam. Madam, how would you approach this woman? Because we often see that they are labeled as perimenopausal bleeds and it is ignored.
Yeah, probably if she's obese and she's dyslipidemic and she's got irregular periods with a thickened endometrium, there is a possibility she may be having other comorbidities also. So I would like to first evaluate her completely, check where she is on the health factor, rule out diabetes, rule out dyslipidemia, etc. Now, coming to the fact that she's got an ultrasound which shows 16 millimeters of endometrial thickness, I don't know which day of the cycle this ultrasound is done, but what I would like to do is, since she has irregular periods, probably give her some progesterone to shed off that lining if it's a thickened lining with irregular shedding. Give her progesterone for 10 days, get a withdrawal bleed, and repeat an ultrasound on day 4 or 5 of the cycle. If the endometrium has thinned out, then I would follow a plan to keep her, endometrium under control, depending on various other factors. But if I find that the endometrium is thick, even on day 4, 5 of a good bleed, then I would like to, incorporate a color Doppler at the same time, which will help me to know whether there is a polyp, which probably I would see even with a regular ultrasound, but with a color Doppler, I would get more information. If I do see a polyp, then I know the answer that I have to do a hysteroscopic polypectomy, remove it, and then probably offer her a Mirena or some method to prevent that endometrium thickening again. So that would help to control her bleeding. But at the same time, the bleeding may not necessarily, it could be because of the adenomyosis, but the irregularity is not because of adenomyosis. It's a menstrual dysfunction. It's a hormonal issue. And therefore, we need to find out what is the cause of her heavy bleeding. Is she hypertensive? So many times we find nothing wrong with the uterus, but she may be hypertensive. But in this case, since we have a pathology seen, we know how to proceed.
Madam, many a times patients ask us if they put in a Mirena, they always ask us whether I will be predisposed to having a possibility of a breast cancer or any other malignancies. They are always very, very scared when you suggest certain things to them. So in your practice, what do you tell them about all this?
Yeah, normally at 48, I would at least do one baseline mammography for our patients as a routine. I mean, the first visit is where we examine them completely. We advise all the necessary investigations. I do a pap smear if she's come for the first time to me, otherwise they come regularly. And then I would also do her mammography. If a mammography is clear, there's absolutely no contraindication to put in a Mirena. So I don't think there is any issue on that. Of course, we must have the family history of the lady, whether there's any history of breast cancer in the family. But we have had patients who have suffered from breast cancer and they have been, say 5 years post breast cancer, and they wanted a Mirena, and I discussed with the oncologist. And especially if they've had a cancer which is not progesterone receptor positive, there's no harm in putting in a Mirena at all. And even if they are ER/PR positive, after 5 years, the oncologist said there's no issue. You can put it in. We'll keep her under observation. So it's a very, very small dose of progesterone. So
absolutely,
we would just counsel the patients and tell them how it's going to help.
Right. Dr. Menon, I would like you to tell us a little bit about the metabolic syndrome, and especially in this patient, if she is sent to you because she is 48 and she has hypertension and diabetes. So how would you like to approach this patient regarding her medical problems? Madam, you need to unmute yourself.
Am I audible now?
Yes, ma'am.
Number one, I would put her on LST. It's most difficult to do a lifestyle modification. But when it comes to diabetes and it is not a PCOS, there is time. And even starting a diet immediately gives a better control of diabetes and hypertension. So whatever she starts with lifestyle and this thing, the drug which I would choose for diabetes would depend upon what can produce a weight loss. And GLP-1 agonist would be excellent here because she's 80 kg. And it also helps to stick to the diet. So we do have a GLP-1 analog, which is going to be extremely useful here. Along with that, we would control hypertension. Even a 5 to 10% of weight loss. For example, if she loses 1 or 2 kgs also at the end of 2-3 months, she is going to start getting the benefit. So we need to do that. Of course, I'll do renal parameters, lipid profile, other aspects of metabolic syndrome, for example, hyperlipidemia, hypertension, etc. All of them needs to be controlled at the same time, and that is what we would do. I would be concentrating on treating her diabetes and hypertension, and choosing drugs which will help her lose weight rather than other way around. Okay.
Thank you, ma'am. Dr. Norman, you have already mentioned to us the importance of doing the examination in such patients as to the waist-hip ratio. And would you please tell us how you would like to tackle this patient? Especially, you must be seeing a lot in your practice of this age group with bleeding disorders.
I think all the comments have been very valuable. I haven't got much to add. One issue that a gynecologist may wish to consider is either turning off the cycles of GnRH agonists until she's 50-ish and then see if her periods have disappeared. Or alternatively, a lot of gynecologists would still be doing hysterectomies given the fact she's got adenomyosis. But this is a perimenopausal woman who's at risk of endometrial cancer because she's diabetic, she's slightly overweight, and she's got irregular cycles. So whatever we do, we have to look after her after the menopause, which often we as gynecologists don't do very well because patients then disappear from us. So whether they go to a physician or to a gynecologist, we need to maintain contact with this patient. Thank you.
Thank you, sir. So that was an excellent summary of the entire case. I would just like a last word from Dr. Menon as to what she would like to tell us gynecologists, because endocrinologists have a different take on many aspects of PCOS. So madam, is there anything specific which you would like us to keep in mind when we treat our patients?
The most important thing I would, can you see me? Okay. The most important thing which I would say is that anyone who walks in for any menstrual irregularity at any age, obesity should be tackled at the first time that you see. Need not be PCOS, need not be any other problem. But we all have to attack obesity from beginning. For example, if a daughter brings the father and mother for diabetes to me, I'm also giving a small lecture without their knowledge that yes, it is familial, it can be prevented by diet and exercise, and tell the daughter that you must start now. Not putting on weight is the first line of defense, because once you put on weight, it is extremely difficult to lose weight simply because of our genetic nature. We have still not, we are still living in the era of, the genes are made for famines and not for plenty, and we have plenty and famines are not going to come. So that is one part of the story. Number two, somebody said that exercise is important. Yes, exercise is important, but 75% of the weight loss which comes is by diet and not by exercise. I always give the example that you eat one roti, which is about 120 calories. If you want to spend those 120 calories, you have to walk more than an hour. So it is easier to give up a roti rather than walk 4 hours because you have eaten 2 rotis or 3 rotis or whatever it is. And I give them the example of this burger and all these things, and I tell them what is the difference between why diet is so important. Number two, going to dietitian helps me, and we should do that and give a diet chart with do's and don'ts. So when they come back and tell me what is life, I can't eat anything, I first sit with them with the diet sheet and tell them what is it that I have prevented you from eating. I have prevented you from eating nothing except concentrated carbohydrates, and I have told them to reduce that, and I have told you how exactly everything can be eaten if you are eating within the limit. So what is avoided is mainly fat for obese people. For diabetes, we also reduce, carbohydrates are all complex carbohydrates which we do, and we tell them that it happens slowly. See, most important factor they have is that they are not going to lose weight now, and they are worried that we have already tried. So you have to tell them that it will take 5 years. You have put on weight over a period of 10 years. You should give them 3 to 4 years to lose weight. And every year, if you lose, in the first 3 months, if they lose 1 kg, I'm happy, because that is the graph which needs to continuously go down, and your benefit will also continuously keep on increasing. Do not expect in 3 weeks to lose 1 kg or 2 kg. It's difficult because then they come back. Lot of this thing is going on craving of food and what it does, and that's why for diabetes and people with PCOS and diabetes, I tend to use more of GLP-1 analog than other drugs. Apart from that, and secondly, when a mother comes for pregnancy, they come only when there is diabetes or something with me or thyroid disease. I start telling them at that time how to prevent obesity in the babies. I think that should be a part and parcel of their counseling. When the mother has come, that's the most compliant time for the mother, because a diabetes mother or GDM mother looks after herself much better than any other diabetes patients I deal with. They're extremely motivated in controlling their diet for the baby. So that is the time we can tell them that your problem came up because of obesity, how to prevent obesity, the counseling, or we should start counseling them at that stage for the babies. It is, Indian culture, or thoda khao, eat a little more is the principle where we live on, and we have to say that that has to be stopped totally. I think that should be okay.
Madam, so that was a very, very good take-home message for all of us. Yes, in India, we do believe it. You are what you eat, and we keep, telling the children, eat this, eat that, but we should stop now and we should look at the larger ramifications of this problem. Dr. Duru Shah, Madam, as the President of the PCOS Society of India, I would like a message from you to all of us, and the last word will be by Dr. Norman. So, Madam, what would you like to leave us with?
I think as clinicians, we need to be more conscious of the fact that we are a pre-diabetic country, and we have a high load of diabetics in our country. And as a matter of fact, as primary care physicians of women, if we are more alert and we counsel our patients well, and we prevent pre-diabetic states, or we try and reduce insulin resistance, probably we may be able to control diabetes better in our country. And I think after China, it's us with diabetes. So we don't want to be number one in that, at least. And we are happy to lose out to China here. So in short, we need to be more alert as doctors and treat women, being their primary care physicians as gynecologists. They usually tend to come to us first. So we definitely need to prevent diabetes and reduce it in our country. And PCOS is a state where girls come to us right from puberty, post menopause, and we should be doing that. And if you educate one girl, you've educated the whole family. So that's what I would suggest.
That's awesome, madam. And I would take this as an opportunity to personally thank you also for this huge initiative you have done with us, with the Thane Obstetric and Gynec Society. And you have been the one who has helped us in inviting Dr. Norman. Dr. Norman, we are really privileged and honored to have you with us. And sir, we would like you to give us a message as to, from your side, what would you like to tell us in India about PCOS, and what would you like us to go home with?
Thank you. I think for all the participants today, the speakers, all of you, have given excellent evidence-based information, and it's a great pleasure to know that our international guideline has been read and taken in by so many people. I'd also like to just tell you how good the PCOS Society of India is. There is no society for PCOS in the world that does the education information as well as Duru Shah has initiated in India. So for those of you not members, I would encourage you to become one, because the newsletter, the programs, the education, I wish we could do that in Australia. So I'm also honored that Duru has asked me to be here today, because she's a great example on how to do the education to all the doctors who want to know about this. Thank you.
Thank you, sir. Thank you so much, sir. I would now close this panel discussion, and I also would like to thank everybody for being here with us today and giving us such a patient hearing. I'm sure we have all become enriched with this loads of information that we have received from the stalwarts in the field of PCOS. I now invite Dr. Mahesh Joshi, the ex-Secretary General of the Thane Obstetrics and Gynecological Society, to propose a vote of thanks. Dr. Mahesh Joshi, are you there? I think Dr. Datta Panandikar.
Yeah, I didn't see Mahesh at all during the webinar. Anyway.
He was there.
Yeah, okay.
He just left. So I think Dr. Datta Panandikar, would you do the honors and thank our speakers?
Yeah. Thank you very much, all of you. Thank you, Professor Robert Norman. We are highly privileged that you could take part in this webinar of ours. And we had so many take-home messages from you. Thank you, Dr. Duru Shah. As Professor Norman pointed out, that ours is the only country which has a PCOS society, and we are very privileged to have you as one of the keynote speakers of the webinar. Thank you all the panelists, Dr. Padma, Dr. Alaka Godbole, Dr. Neelima, Dr. Supriya, Dr. Rachana, and of course our phenomenal moderator, Dr. Sandhya Saharan, who's taken so much pains for this webinar. Thank you, the Switzerland division, Dr. Shubhojit and Dr. Patania. Thank you very much for your help, because you had to come in at the last minute at a very short notice, and you did your best for us, and we are highly obliged. Thank you everyone, and thank you Dr. Laul for giving us this concept. Thank you all of you, and I think we can stop the webinar.
Yes.
Thank you.
Thank you everyone. Thank you, Sandhya, for a great job. Thank you, Laul sir and Datta sir.
Thank you,
Dr. Norman, Duru Shah ma'am, it was a real pleasure to hear you. It's really, we cannot even describe. Thank you so much.
Thank you, everyone. It was great to share the stage with Dr. Norman, Dr. Duru Shah, Dr. Padma, Menon, and everyone at DOJ.
Padma madam, really so many of our concepts have really cleared out. Thank you so much, ma'am.
And thank you very much for inviting me. I learned a lot today.
Thank you.
No,
all.
because you know, see, I have things which I don't read, no? So I learned a lot.
Thank you. Bye-bye.
Bye.
Bye-bye.
Thank you, everyone.
Bye.
Thank you, Mr. Patania and Mr. Abhijit. You, as usual, have been very, very helpful. So thank you very much to both of you. Thank you.
Ranjit.
Ma'am, can I end the meeting?
Recording is there, no?
Yeah,
Yes,
you
yes,
can.
sir.
You
Yes,
can.
sir. Yes, sir.
Send the link for recording.
Yes, sir.
And you can stop the webinar.
Thank you, Lord, sir.
Okay, sir.
Bye-bye. Good night.
Thank you, Lord.
Oh, good,
I'm
good
ending the
afternoon.
meeting now.
May I just request all participants to join us tomorrow 6 o'clock for another very interesting PCO panel on adolescent PCOS, and also a talk by Dr. Jaideep Tank on adolescent endometriosis. So I'm inviting everyone. I'll be sending the link in all the TOGS groups. Thank you very much.
Thank you, all of you.